Good afternoon. My name is Chloe, and I'm one of the third-year general surgery residents going out into research next year. Very happy to share this work. I actually participated in some research on CSF as a medical student, also with my PI, Dr. Miles Berger, which was incredibly about 6 years ago now. So this research is very near and dear to my heart. As an audience of mostly general surgeons and affiliates, I know that many of you must be wondering what cerebrospinal fluid has to do, how it's relevant to your practice. But I hope to convince you in the next 8 minutes that CSF and postoperative delirium and cognitive outcomes after surgery is imperatively important to our practice, especially as all of our patients age, and all general surgeons will ultimately become geriatric surgeons. Except I guess the pediatric surgeons, Dr. Chu, although children still do develop delirium as well. So postoperative delirium is not only a very common complication, it also affects your patient's morbidity and long-term mortality with up to 3 times likelihood of developing Alzheimer's disease if you screen positive for postoperative delirium, even as early as in the PACU. We currently lack reliable biomarkers, in a large part because our systems biology understanding of delirium is lacking. There are 2 leading theories about the pathophysiology of delirium. First, neuroinflammation, which I believe in more, or inflammation leading to a leaky blood-brain barrier, which allows acute phase reactants and inflammatory cells and cytokines to enter the brain. There's a second brain metabolism hypothesis, which when you have an increased metabolic demand, acute stress of surgery, inflammation, the neurons now have insufficient metabolic fuel. CSF is our fluid in close biochemical equilibrium with the brain, but it's difficult to access except via lumbar puncture. Our group developed a protocol to do safe lumbar punctures, even in preoperative patients, with no delays to your first case start time. We published this in 2021. There was a very low complication rate and very low associated overall pain scores. We then use this protocol to enroll patients over 60 undergoing non-cardiac, non-neurologic surgery at Duke. CSF was collected under the Intuit and MADCO-PC protocols. These looked at inflammatory markers as well as Alzheimer's disease biomarkers respectively in the CSF to see if there were changes in patients that did develop delirium. And we screened for delirium using validated metrics, the CAM and 3D CAM, and we had very good inter-rater reliability in our studies. Our time points, we consented people to receive lumbar punctures preoperatively, 1 day postoperatively, 6 weeks postoperatively, and 1 year. In this study, we performed multi-omic analysis, so we used flow cytometry, cytokine profiling, metabolomics, proteomics on our CSF. For our statistical approach to identify biomarkers out of all of this data, we use a combination of 2 methods. One is LASSO, which is a more traditional machine learning for big data, and one is STABLE, which is a novel supervised machine learning framework recently published by our collaborators in the Gaudier lab. STABLE uses noise injection to help solve the P versus N problem, namely that there are millions of comparisons that we need to make with these data sets for which nothing would survive significance after multiple comparison correction using traditional statistics. So noise injection and modeling allows us to pick out the truly sparse and reliable biomarkers. And out of all of this data, we found 7. T-SNE stands for T-distributed stochastic neighbor embedding, and I am always like mesmerized while looking at this graph. Each dot represents a specific omics data set. It's all color-coded, and their relationship in space to each other shows how similar the 2 data points are. So for example, in our metabolomics, you might have cellulose and sucrose, and those 2 are blue dots coded very closely next to each other. We might have Alzheimer's disease biomarkers in green, cytokines and flow cytometry data was in purple. And you can see that out of the 7 biomarkers that STABLE chose, they're all clustered together and mainly in the flow cytometry and cytokine profile. Our integrated lasso model on those 7 biomarkers achieved an area under the curve of 0.7, which is fairly good predictive performance in our model. And this is using the preoperative and 6-week postoperative time points. In figure B, we have our stability path that highlights the regularization parameter and selection frequency. So with our dotted line being the selection frequency threshold, and with each black line showing a different metabolomic marker. There was only one variable that passed that threshold, which was cellobiose. But you can see when we look at flow cytometry and cytokines, we had 6 other biomarkers pass that selection threshold. And I believe that this data altogether supports the neuroinflammation hypothesis of delirium. So in conclusion, we took CSF from postoperative surgical patients, performed multi-omic analysis using flow cytometry, metabolomics, proteomics, and then analyzed and integrated all of this data with machine learning to identify features associated with delirium. This data, to our knowledge, is the first study to use machine learning techniques to identify features associated with delirium and essentially allow us to test different systems biology approaches simultaneously. This data makes me excited to be going out into research next year, and I really hope that I've inspired at least one of you to care about delirium and CSF in your practice. I'm happy to take any questions.